Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today I'm with Ryan. How are you doing today?
Doing pretty good. See you again.
Nice to see you again. So today I'd like to talk about hemorrhagic fevers. There's a bunch in the world, and just from my quick Google search, all of them sound scary. So I asked you to come on and kind of calm my fears.
Yeah, well, I don't know how much I'm going to calm your fears. These are very dangerous pathogens, and when we talk about special pathogens or high consequence pathogens, viral hemorrhagic fevers are very high on that list, along highly pathogenic respiratory viruses like, potentially avian influenza in the future. But yeah, so viral hemorrhagic fevers are, kind of collectively a group of illnesses that are actually, caused by different families of viruses. But, if we want to talk about a prototype, the one that we really think of when we're talking about viral hemorrhagic fevers, we're really thinking Ebola, right? So Ebola is a filovirus. It's called that. Philo is like filament, and when you look at it under a microscope, it looks very filamentous. Ebola is actually a group of different viruses. There's Zaire Ebola virus and Sudan Ebola virus, but they cause overlapping syndromes and they're closely related. And then there's Marburg, which is also a filovirus and causes pretty much the same kind of disease. There are some other big ones out there. There's Lassa fever, for example, which is endemic in parts of West Africa. And then, a little closer to home, we have things like dengue, which is in a lot of Latin America and also pretty widespread around the world. Now, dengue usually doesn't cause particularly severe disease in healthy people, but, kind of the joke, I don't know if it's a good joke, but the line around in that ID doctors sometimes say that malaria will kill you, dengue will just make you wish you were dead. And there's a severe form of dengue called dengue hemorrhagic fever, which is particularly severe. It doesn't have the same transmission risks as like Ebola or Marburg have. It's spread by vectors. It's spread by mosquitoes. And then yellow fever, right, which is largely a disease of historical interest for those of us in the United States. But was once endemic in the U.S. During the Revolutionary War. There was a yellow fever epidemic in Philadelphia, for example. And now it's no longer endemic here, and there's a very effective vaccine for people living in endemic areas. But there are still periodic yellow fever outbreaks in, Brazil, for example, and those can be life-threatening. And it's called yellow fever because jaundice is a major component of it. But that is another kind of classic yellow fever. Another classic viral hemorrhagic fever.
I guess what is causing like the bleeding, the hemorrhage? I mean, is it really hemorrhage?
It's more like oozing. I mean, overt hemorrhage is actually not a major feature of at least of Ebola. So that was one of the interesting things that happened during the 2014-2015 Ebola epidemic in West Africa, in Liberia, in Sierra Leone, in Guinea, spread a little bit into Nigeria before that outbreak was aborted, was actually that it was more cholera-like. And that was a comment a lot of people involved in seeing it, that there are hemorrhagic components. You can see like mucosal bleeding, you can see gastrointestinal bleeding, you can see oozing at IV sites, conjunctival bleeding, red eyes. But really the feature that a lot of folks saw was just massive volume losses, massive amounts of diarrhea and fluids. And so a lot of the care involved was just fluid and electrolyte replacement, was keeping up with people's volume status. And of course, one of the dangers of this is that fluid that's coming out of people's bodies is itself highly contagious. And kind of keeping on top of that, of the waste requirements of how do you take care of all of that infected fluid and all of that infected medical waste that goes into caring for those patients is one of the big challenges for caring for one of these patients. And that's why the care for these folks tends to be done in highly specialized units, at least when they arrive in industrialized countries. When patients arrive at, for example, in the States, we have a number of special pathogen treatment centers throughout the country that have the capability of caring for these patients safely. And then overseas, a lot of this care was done by volunteer organizations, by Doctors Without Borders, by national governments. We provided some care. The U.S. during 2014, 2015 mostly provided laboratory and logistical support. That laboratory support was largely done by the Navy, by the U.S. Navy. A whole troop of Navy microbiologists and microstaff going overseas to provide direct support, which was very risky work, direct work with highly pathogenic viruses. My old neighbor, actually, at the time, Lieutenant Commander Ben Espinoza, was featured in the New York Times for going over and running a lot of laboratory testing there. Go ahead.
No, I was just mentioning, so all like the, stories like the New York Times, they don't show you pictures of the guy when he first walks in. They show you the bloody aftermath.
Yeah.
Because, that's what solidifies those diseases in people's minds. Right. Everybody starts with like, man, I don't feel good. What are some of the signs and symptoms? And I guess ultimately I'd like to know, how do we differentiate
them? Yeah, no, exactly. And that becomes the challenge, right? That the early stages of these diseases are undifferentiated febrile illnesses, right? There are some features that can be more suggestive of one or another. Lassa fever, for example, tends to present with a sore throat. Pharyngitis is one of its kind of more distinctive features. But, when you first start out, you have like you're saying, a nonspecific influenza-like illness, right? Maybe not a lot of respiratory symptoms. That would be more unusual. Abdominal pain, myalgia, muscle aches and pains. But early on, it looks like everything else. And this is always the big concern, right? That these diseases, these entities are hard to diagnose up front. And unfortunately, they progress very rapidly once you reach a certain stage, and that stage is pretty early. There is when it comes to diagnostics, most of those diagnostics have to be done. There's no rapid test, right? That the testing, in the States anyways, is largely done through state public health departments, and then to the CDC, or in the military, it can be done by USAMRIID. And some of the larger military labs like RARE, like the Walter Reed Army Institute of Research and the Naval Medical Research Center and places like that. But your hospital lab isn't going to have it. You're not going to have a card in your backpack that you can do a rapid test like you can for malaria. It is, and this is probably one of those places where the role of medical intelligence plays a big deal about when deploying to an austere area, having some idea of what's endemic out there and what's to look for, because it's going to vary a bit. Ebola and Marburg tend to kind of flare up in areas, and hopefully we at least have some visibility on where those endemic areas are so we can be somewhat prepared for it. Some diseases like Lassa or Crimean Congo hemorrhagic fever, kind of persist as low-level endemic diseases all the time. And there's always a certain risk for them. And if you're looking at like Lassa, again, you have, spread by rodent feces, basically. And so this is one of the arguments for keeping a field site as free of rodents as we can, because they are vectors of disease, not just, Lassa, but other highly pathogenic things like, plague, for example.
Preventative just preventative medicine, always key when it comes to just camp maintenance. And then you have your civil affairs missions going out to the local communities and trying to provide those resources as well. So hopefully they don't get sick. But obviously keeping as much of the wildlife out of your camp is always, it's always a bonus.
Yeah. That's probably broadly true wherever you are. I grew up backpacking in the North Cascades with my dad, and keeping the wildlife out of your camp is useful no matter where you are.
So, you mentioned, medical intelligence, like there's no, like if you're going into like an area that has had Ebola in the past, like you're going to know it. Everybody's going to let you know that this is what happened in the past.
Right.
We don't carry those giant, positive pressure biosuits with us.
We do not.
It's just not in our inventory to order.
Not usually, no.
So what realistically would you use? Because, like you mentioned, like having some kind of base level protection, probably just to see anybody who's coming from the community, would you pack with you?
Yeah, I think, most of these things, again, looking at Ebola, we treat Ebola with very high level precautions because the risk of transmission and the consequences of transmission is so great. Ebola is not actually airborne. If you work hard in the laboratory like primate models, you can demonstrate aerosol transmission non-human primates. But really, the reason for all of the spacesuit is to minimize contact, right? That these are largely spread through direct contact with infected bodily fluids. So anything you can do to minimize that contact. Eye protection is often overlooked and incredibly important. I was watching The Pit on HBO last night. Generally great show. Every now and then, I do chafe a little bit about like, hey, during that procedure, you should, I realize you're actors and we have to see you, but put on a mask and some goggles, son. Right. But eye protection is a huge thing because conjunctival transmission is actually pretty important, right? And that's true of influenza. That's true of a lot of things. And so both consciously minimizing touching your face, which is hard to do, right? If you walk around during the day and you think how often you touch your face, it's a lot and it's all the time. But minimizing contact with your face and eye protection to keep things out of your eyes would be a major part. Obviously, some manner of mask. I just said it's not transmitted by airborne, or at least most of them are generally not airborne transmitted. But nonetheless, if you got a couple N95s with you, I'd put them on. Being very careful in the donning and doffing process, right? And this is a place where a very simple checklist of someone who is watching you and talking you through the donning and doffing process is going to be important, because doffing is probably more dangerous than donning. And then some manner of fluid impermeable coating. I'm not talking about like a Tyvek and a spacesuit and the PAPR and all that stuff, which we don't care, but just, some sort of sturdy, heavy apron to cover you, something to cover your boots, and then good heavy gloves. If you only have regular gloves, I would certainly double glove. When we were setting up Ebola response teams, and I never deployed to the Ebola lands, although a number of us kept asking, and a good friend of mine, who was another Navy ID physician, managed to sneak over there to work in a field hospital. And there are a number of military physicians who were able to engage in direct patient care over there. But one of the things we were doing, we were setting up the teams, is just using like duct tape or some sort of heavy tape, something that are, reasonable, and use that to seal, your sleeves over your gloves to minimize the stuff being able to leak in and protect your exposed skin. And those are things that kind of PPE is, you'd have to make the conscious decision to bring it with you, but it's not particularly hard to find, and it doesn't take up a lot of space. So good N95, good eye protection, sturdy gloves, something fluid impermeable, a fluid impermeable apron, covering up any exposed skin as best you can, and then generally something to cover your shoes as well.
Okay. And that's just so you're not tracking it around the camp as well.
Exactly. And then having a buddy system where you're watching each other don and doff to make sure that in the process of removing infected material, and there's a specific way to do it, but it's not terribly hard, but it needs to be done with observers, and then regular washing before and after, including before you doff, actually like disinfecting your gloves to minimize the amount of gunk on them to minimize risks while doffing. So you wash your gloves, then you take them off, then you wash your gloves, and you wash your hands again, and then doing that sequentially during the removing process.
Okay. So if you wouldn't mind, let's start walking through kind of some signs and symptoms, and then maybe we can get into some of the treatments.
Yeah, absolutely. Absolutely. So, early on with these entities, you're looking at mostly a nonspecific febrile illness. With Ebola, we're talking about usually progression to, there will be some hemorrhagic manifestations. I mean, they're called hemorrhagic fevers for a reason, but that is rarely like overt spontaneous hemorrhage, right? You may have some melena, you may have some GI blood losses, bleeding at the sites of IV insertion. That actually, now that I say that out loud, that occurs to me, that might be one of the earlier clues, right? And kind of like someone in DIC, where you're placing an IV in someone and there's just a lot of bleeding and oozing coming out there, much more than you'd anticipate in an otherwise young, healthy person. Mucosal bleeding, you may see some petechiae or purpura inside the mouth, and then, maybe some conjunctival hemorrhage as well.
Okay.
But usually high
early?
fever, that can be early. But typically it's going to be myalgias, high fever, headache. In the case of Lassa, sore throat. Though they start out as very nonspecific. And then in the case of Ebola, fluid losses tend to come next, right? With some other things, what you might see are signs of hemoconcentration if you have a way to check a hematocrit, right? Because you're having a lot of capillary leak into your tissues. And one of the early effects of that, and this is one of the things that throws people off about hemorrhagic fevers, you may actually have a high hematocrit, right? Because you're actually hemoconcentrating. And so an elevated hematocrit, you've got a crit of if you figure 45-ish is about normal for a young, healthy person of military age, 45 for a man, 35 to 40 for a woman, depending. A high crit above 50, 55 or so, that can be one of the suggestive features. So one of my first consult patients as a ID fellow in the Navy in San Diego was a young man with dengue hemorrhagic fever, which doesn't have the same transmission risks, right? He was on a regular ward. We just had to do standard precautions, wash your hands. But a high hematocrit was one of his kind of presenting features. High hematocrit, in his case, low platelets as well, depending if you are able to check a CBC. But hematocrit, you might be able to check in a field environment.
Yeah, we have the iStats, so
yeah, iStats would give you a crit. Yeah. So with that, then fluid losses tend to be the big thing. And again, I say cholera-like, but what I mean by that is large, massive volumes of stool, which may have some blood in it or may not. And so that kind of gets us into what are the treatment aspects of it. Most of the most effective care in Ebola was supportive care, right? That was providing, fluid replacement, electrolyte replacement, and the like. Secondary infections are thought to be pretty common. When we were coming up with, treatment pathways, we spent a lot of time deciding, do we just give people antibiotics empirically if they're in shock? I mean, it is sepsis of a sort. We thought about, do we treat people empirically for malaria if we don't have a way to rule it out? And I think that's still kind of an open question. And certainly someone who presents with an undifferentiated febrile illness in, for example, West Africa, I would never give anyone a hard time for treating that person up front for malaria, along with working up whatever supportive care they need. But the great majority of the care is supportive. And aggressive early supportive care is the thing that had the biggest impact. We thought that Ebola had like a 95% mortality. And it turns out the people who got care in Ebola treatment units in West Africa had a survival that was much better than that. Their mortality is still very high. But our mortality, in people treated in Ebola treatment units in Europe and in North America were pretty high. It was 75 or so percent. I mean, most of those people lived, not everyone. There were some very tragic deaths. But I have an acquaintance who survived Ebola and has continued to have kind of oddball, interesting health problems along the years. One of the concerning parts about Ebola is that it persists in what we call immunologically protected sites in our body. So at one point, this gentleman, one of his eyes changed color because the eye doesn't have much of an immune system inside. There's not, so for a variety of reasons. Ebola can be transmitted through semen for often many months afterwards, and so that can certainly be an issue. Delayed sexual transmission of Ebola. So there are long-term consequences of it, and these people require ongoing care, and often are sort of devastated by being survivors of critical illness. And have prolonged recoveries. Most of the care is supportive. There are some investigational therapies for Ebola and a few of the others specifically. I say investigational, they're just, they were used and they were studied, but they're not, you can't go to the supermarket or the pharmacy down the street and pick them up. Monoclonal antibodies, ZMapp is one that was used. That seems to be pretty effective. There are some effective Ebola vaccines out there now. The Army was pivotal in development of some of them. And those are available for deploying units. I can't say that I'm aware of any deploying units ever receiving them, but they do exist, and they could be obtained in theory. And those have been very effective for large scale Ebola outbreaks in the DRC and elsewhere. There's no real, other than the monoclonals, there's no real drug therapy for it. A lot of things were tried, and actually remdesivir, which is an effective agent for the treatment of COVID. Remdesivir, one of its early uses was for Ebola. It was actually one of the things it was originally designed for. And it turned out that, by the time you've made the confirmation of Ebola, the cat's kind of out of the bag there. And so it didn't have a lot of impact. But we actually got a lot of our early safety data for remdesivir, particularly in pregnancy, from the Ebola trials of remdesivir. So we could look at it and say, well, it wasn't particularly effective in treating Ebola, but we also know that it seems to be safe in pregnancy because a number of pregnant women received it on an emergency basis during Ebola. Yeah. So there's no real drug for it. There are a few of the other viral hemorrhagic fevers that do have specific therapies. One thing we'll sometimes say in ID is that no virus is totally untreatable until we've thrown ribavirin at it. Ribavirin is a very broad spectrum antiviral. Doesn't work for everything or a lot of things, but it seems to have some efficacy in Crimean Congo hemorrhagic fever. That's spread by ticks, by the way, and then through contact with infected blood or tissues. And there is at least one U.S. military death from Crimean Congo hemorrhagic fever during CENTCOM engagements in the last decade. So that is a potential threat out there. Ribavirin seems to have some activity against CCHF, against Crimean Congo, and against Lassa fever. But most of the others don't really have drugs. And other than yellow fever and Ebola, most of them don't have vaccines. And this is a major countermeasure problem, and something I think a lot of groups are working on.
Just like you mentioned, just reading up on some of these diseases, are all of them RNA viruses?
Yeah, actually, they are pretty much all RNA viruses. Yeah.
So just kind of like COVID, I guess.
Yep. Yeah.
That's probably one of the reasons why vaccines are so difficult, is because this thing just constantly changes.
Oh, I don't know. I mean, part of the problem with hemorrhagic fevers is they occur sporadically, right? And it's a challenge. I mean, we have effective Ebola vaccines now, but it's not like there are a ton of people around with Crimean Congo hemorrhagic fever to do a proper vaccine trial. And there are a number of DNA viruses like influenza, for example, that are also kind of challenging from a vaccine standpoint. So that's not as surprising as it might be. But yeah, I mean, I would say probably most viruses are I think RNA viruses that infect humans. I'm sorry, that was, take that back. Influenza is actually an RNA virus. It's early in the morning. I had a bit of I had a low grade seizure there. Um, there is something unique about it, that influenza is unique among RNA viruses, that it replicates in the nucleus of host cells, not in the cytoplasm, which is where most RNA viruses replicate. That's why I had a little bit of a seizure there. But they do tend to be more prone to mutations, right? But there is some variation there. I think part of the problem is just that, to be blunt, these are diseases that largely affect poor people in resource limited settings of the world, and the financial impetus to develop vaccines for these is not what they are to develop vaccines for, say influenza, a much more cosmopolitan infection.
Right. No, that definitely makes sense. It's sad, but it makes sense.
It is. It is.
So this also seems, just from, signs and symptoms, voluminous diarrhea, etc., but just controlling bodily fluids, this is going to be like a super nursing heavy disease. It is. With all of the bodily fluids being incredibly contagious.
Yes, that's exactly the problem. And a big part of planning for the care of these patients, both at home and overseas, is your waste management plan. How are you going to dispose of waste, and where do you put all of that medical waste, and how do you get rid of it? I mean, do you move it, 100 yards away from camp and burn it? I mean, that might be the best thing to do in a field setting. At home, when places like Emory and NIH and other places that have containment units, University of Nebraska, they have to work very early on with, the local, municipal authorities on figuring out what is their waste disposal plan. And how do we get rid of this? Can you pour something down the toilet? What are you doing to the municipal water supply if you pour something down the toilet? Those sorts of challenges. And another sort of practical thing is, the sicker people get, the higher their viral loads are, and the greater the risk of transmission. And that actually persists after death. And one of the ways that Ebola was very sadly transmitted in Liberia and other countries in West Africa is that it's customary for people to, hold and, embrace the bodies of their deceased loved ones. And a lot of people got infected through that route. And, I think we've all seen that it's very hard to, change the sort of deep-seated, cultural habits and beliefs. And so being cautious with if someone does pass away, being, how do we both respectfully care for the remains of this deceased person while also protecting ourselves? Yeah.
I had like a really good question, and then I forgot it. But
that's all right. We'll come back to it.
That's all right. I guess I can. That was also my last question. But is there anything, if you were going into the wilderness, right?
Yeah.
In an endemic area, you're going to have limited supplies. So
you are.
This was the question. You come into contact with a patient who you think might have some kind of hemorrhagic fever.
Right.
It just, whatever about you, your spidey sense tells you, like, this is somebody that I'm probably not going to be able to handle. Who would you reach out to?
Well, it depends on where I am, right? A number of countries with endemic disease do have systems of care around there, right? So, for example, in West Africa, there is sadly a great deal of experience among many people in the care of these kinds of patients. So seeing what my local resources are in the local civilian or military sector, local, host nation partners and the like. If I am dealing with an American, I would be contacting, there is a network here, NETEC, it was originally the National Ebola Treatment and Education Center. Now it's the National Emerging Special Pathogens Treatment and Education Center, but we kept the NETEC acronym. NETEC has a number of units across the country and experts at these units to help. There are ways, for example, to transport, to do high containment transport. And the Air Force has done a lot of work in collaboration with the University of Nebraska in setting up ways to transport infected patients from overseas back home to a containment unit. So people institutions to reach out to. The University of Nebraska would be an excellent one. NIH is an excellent one. Emory University in Atlanta are an excellent one. We're starting up a containment unit at UNC down there. I say we, I have nothing to do with it, but we as a country are starting up one at UNC, an hour and a half away from here. And then, on the West Coast, Cedars-Sinai has one, and I believe they might be starting up one at the University of Washington, but I'd have to double check that. It actually might be Sacred Heart in Spokane, now that I think about it, closer to Fairchild Air Force Base. But so there are mechanisms to transport these people back home in a timely manner. And that is probably the safest thing to do if we're talking about a military member. But having some idea of what your host nation resources are, but these are not people who you can safely manage in a level one or, a role one, role two kind of setting. And honestly, even in a more mature theater, I'm thinking back to my time in Kandahar. Infection control was difficult even in a hardened facility, right? Like we had a guy with disseminated varicella in my very fancy deployment hospital, and that was a nightmare to try to figure out how to protect staff. I wasn't too worried about. Everyone was varicella immune, but thinking about the Afghan patients, how do I protect them from a potential airborne threat? These are people who, if you have a reasonable index of suspicion, they got to go. The diagnostic testing cannot be done in theater, and the care, especially if they're going to have, if the diagnosis is confirmed and they have, reasonable odds of survival, that's going to have to be done at home. But fortunately, we have a lot of expertise.
Yeah. I mean, I could easily imagine, thinking this guy has a cold or a flu or something like that.
Yeah.
Just because it's like 190 degrees outside, you're like, hey, I'm going to throw this guy an IV and get him some fluids and fill him up a little bit. And then you're like, he suffers a shock of like his IV sites are bleeding, and they don't want to stop on their own.
They do not.
I remember this podcast, and you're like, holy crap.
Yeah, exactly. But, I think one good thing too is that, there are a lot of military, there's a lot of military expertise on these diseases. And there's a lot of former military medical officers who have devoted their life's work to this. And we still, even though we're not, and I say like I said, I was always sort of Ebola adjacent. But guys like James Lawler at the University of Nebraska, also at Nebraska, David Brett Major, Mark Corda-Peter at USIS. There are a lot of people who spent their careers in the military working on very, very much this problem, and still continue to work with the military on how do we safely identify, transport, and care for these folks. And the Sea Stars program, again, at Nebraska, is one of the big ones that can be helpful in transport and tapping into that expertise. And that is that ongoing Air Force program.
Perfect. Is there anything else that we missed that we need to talk about?
I'm sure there's a ton, but it's a big topic. It's a big topic, and it's a very heterogeneous group of diseases and viruses. But the core issues of good early supportive care and staff safety, right? Good PPE. That doesn't have to be full-on spacesuits, but if you look at the pictures of like MSF hospitals, they weren't wearing PAPRs, they were wearing N95s, face shields, and then just kind of heavy aprons that were fluid impermeable. Those sorts of things, early recognition, early supportive care, and then protecting yourself. Waste disposal, that would be the fourth thing. and making sure you're never alone, right? Making sure that there is someone there who you are backing them up on their safety. They are backing you up on their safety. I think those are going to be the essential keys early on. The more advanced diagnostics, advanced therapeutics, that's going to require getting that person out of there. But I think we have it. We're beginning to develop those tools.
Awesome. Well, thank you, Ryan. I really appreciate it.
Pleasure's mine. It's always great to see you, my friend.
That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC podcast. Out.